Hello and good afternoon. My name is Mike Willett with the Intertribal Council of Michigan. Welcome to our webinar titled Supporting Referrals to the Michigan Quitlink and the American Indian Commercial Tobacco Program. Your presenters today are Dr. Thomas Ylioja, Clinical Director of Health Initiatives from National Jewish Health, Dave Woodruff, Account Manager for Health Initiatives at National Jewish Health, and Karen Brown, MPA, Tobacco Dependence Treatment Coordinator for the Michigan Department of Health and Human Services. No commercial interest support was used to fund this activity. As a result of participating in this activity, the healthcare team will recall the background on the development of protocol for the American Indian Commercial Tobacco Program on the Quitlink, contrast the difference between the AICTP program and the Michigan Tobacco Quitlink program, describe the types of referral mechanisms available for providers on the Michigan Quitlink and AICTP page, and timing of provider feedback, discuss a walkthrough of the Native American caller's experience on the AICTP, and employ information on free NRT available to Native Americans who enroll in the AICTP or the Quitlink. If you have any questions during today's presentation, please type them into the question box on your Zoom panel. The questions will be answered during the last 10 minutes of our presentation. Also, we'll have our Director of Health Education and Chronic Disease, Laura Fisher, and Dave Woodruff from National Jewish Health on our chat box, monitoring the chat, facilitating any questions there. Also, we will be archiving today's webinar, and we will have the archive available by the end of the week this week. Thank you very much. And now at this time, I will toss it over to Karen Brown.
Good afternoon, everyone. I'm just going to do a quick update and background on the Michigan Tobacco Quitlink. The Michigan Tobacco Quitlink started in 2003, and it was called the Quitline at that time. And it originally operated only in the Upper Peninsula of Michigan, and that was just due to funding and just a really a soft launch. In 2004, it opened up to the entire state. Um, we offer multiple services, which you'll hear a little bit more about in a few minutes. But just wanted to let everybody know that one of the things I do at the Michigan Department of Health and Human Services is manage this contract. So if you have any immediate questions, if you're having trouble with one of your clients and it sounds like, they're telling you they have questions or a complaint or anything like that, please call me right away. My number is 517-335-8803. I can get in touch with our Quitlink provider, which is National Jewish Health, and we can look up your client, see what's going on, and get some information back to you and troubleshoot any problems. So the sooner we know about that, the sooner we can help. We certainly like to provide that service. So please let us know. With that, I'm going to turn it over to Thomas Ylioja, and he's going to tell us a little bit more about how the American Indian Tobacco Control Program came to be as part of the Michigan Tobacco Quitlink and what's different about both programs.
Thanks, Karen. And I'm going to share my screen, so hopefully you're able to see my slides as I go through them. I won't be able to see you, so please, as we're going through, please feel free to enter any questions into the chat or into the Q&A box. And if we can answer them on the fly, we will. Otherwise, as Mike mentioned, we'll take some questions at the end. I'm going to walk through a few slides here just to kind of give you some information about the American Indian Commercial Tobacco Program, Just want to thank the Intertribal Council of Michigan Indians for the privilege of being part of your webinar today, and to talk about our program. The program is delivered by National Jewish Health, as you heard, which is located in Denver, Colorado. And I just want to take a moment to honor and acknowledge that we are on the traditional territories and ancestral homelands of the Cheyenne and Arapaho nations here in Colorado. Well, first, a little bit about us. It looks like I've got a little bit of a screen lag here, so I'll try not to get too click happy and advance too fast through them. But a little bit about National Jewish Health. We've been around for a very long time now. Since 1899, National Jewish Health opened their doors to serve patients here in the Denver, Colorado area. We've been, and for that entire time, I realize now I've got a typo here, because we are now at 125 years of service in the respiratory health arena, primarily in the Colorado region, but people do come from all over the country for specialized respiratory care at National Jewish Health. We were founded originally to work on the tuberculosis epidemic, where at that time one of the best treatments that people could get was high altitude, dry air, and lots of sunshine, and we get that in spades here in Colorado. So a lot of people were coming here for treatment of tuberculosis, and there wasn't very many treatments available. And a lot of the folks who had tuberculosis were indigent communities or indigent people. And so National Jewish Health was founded as a charity hospital and never took a dime of any money. It was entirely a charitable hospital with a charitable mission for, I think, the first 70 years of service, which was really quite a phenomenal thing. Today we are one of the top respiratory hospitals in the nation. We are nonprofit, non-sectarian, and an academic medical research center. So every dollar that we earn through initiatives like Quitline and Quitlink initiatives goes back into supporting our mission to improve respiratory care for people across the country. Today we are the Quitline service provider for 22 different state Quitlines, and we have 3 additional states where we operate just our My Life, My Quit youth cessation program. Those are not the topics of today's presentation, but I will talk a little bit about Quitlink, just in particular to talk about how what that means for the American Indian Commercial Tobacco Program. So first, a little bit about Tobacco Quitlink and the program features that we have. So all of the coaching that is done through Quitlink is with trained and experienced tobacco treatment specialists. National Jewish Health is an accredited tobacco treatment specialist training program. So we have folks go through a pretty significant amount of training. It's about a 3-week training program for our coaches, very heavily focused on motivational interviewing, stages of change, with a smattering of things like cognitive behavioral techniques, goal setting theories, those sorts of things to really help people along their journey towards quitting tobacco, or quitting commercial tobacco. And the other pieces that we have as part of the program, so the mainstay is still sort of that telephone coaching, but we also have digital services like our mobile optimized website, interactive text messaging programs, email messages. We have an e-coaching chat platform where people can, when they're on the website, are able to engage with one of our coaches live, and never a chat bot on there. They do have to answer one question just to make sure that we weed out any bot traffic, but otherwise they're always connecting live with one of our coaches. We also deliver a live text coaching intervention for youth and young adults through a short code where they can enroll directly. We offer nicotine replacement therapy. We do have, in some states, we even offer prescription medications, but for the most part, what we're able to offer is things like nicotine patch, gum, and lozenge. And then we supplement that with personalized education materials. And so what we do, and I'll show a couple of examples in a minute here, but we personalize those education materials to the participant based on what they answer during their intake questions. So for example, if somebody has COPD, we want to make sure they get a little bit of information about COPD, or if they have heart disease or diabetes. And that includes for some of our priority populations where we actually have tailored education material just for different populations as well. So I want to talk a little bit about how we work with what we call priority populations. These tend to be groups of people who have either higher rates of commercial tobacco prevalence in their communities compared to the national average, or sometimes compared to state averages, or they have cessation-related disparities, so maybe they have lower quit rates or some other challenge or barrier to quitting that we're trying to attend to. And so we sort of group all of these together under a title of priority populations, because these are our priorities. And we approach this in several ways. One of those is that we provide a lot of training for our coaches with subject matter experts. So all of our coaches attend about 40 hours of continuing education and supervision every year to make sure that they are staying up to date, that they have the latest content. We bring in a lot of guest speakers to supplement the content that we have to really help people with our coaches understand the populations that they're working with. And then we use that training to help develop coaching guidelines and participant education materials. Here you can see on the screen, not very well, but some PDFs, and these would be examples. So for example, in our American Indian Commercial Tobacco Program, we make sure that everybody gets this, the top one here, the Commercial Tobacco Use and You participant education piece. We do additional things like have web pages and video testimonials available wherever we can, either on the QuitLogic site, which is the Quitlink website, and then we even have a dedicated program website for the American Indian Commercial Tobacco Program, as I'll show you in a few slides. We do things like evaluation projects where we really focus in on priority populations to understand how well our programs and services are delivering care to the people who really need it. How do we make sure that these priority populations are being reached equitably and that they have equitable cessation outcomes, or what else could we be doing to better support a priority population? And out of a lot of these, out of the evaluation projects that we do has grown special programs that we deliver. So for example, we have a pregnancy and postpartum program that developed out of a need to help people with staying quit postpartum when relapse rates are really high. A lot of times people are returning to their pre-pregnant self, and returning to commercial tobacco use is often one of those components of that postpartum experience. And so we have a program that is really designed to help people stay quit postpartum. We have our My Life, My Quit program, which is specifically for youth and has been tailored to youth. We have a behavioral health program that is delivered through Quitlink, where people who report having a behavioral health condition and feel like they need additional support can access that through more coaching calls and more tailored coaching services delivered specifically for folks with behavioral health conditions. And as you'll hear about a lot more today, we also have our American Indian Commercial Tobacco Program that has been around since that launched in 2015 with the support of several states, including Michigan. A quick note about terminology. Today I'm going to be using American Indian fairly extensively because that's what the language was in our original program, but understanding that over time it reflects our culture, and that as our culture changes, our language changes. And so wherever I can, I mean to use Indigenous Americans or Indigenous peoples, Native peoples, or American Indians. You'll hear me use those sort of interchangeably. So a little bit about commercial tobacco use, probably not a surprise for this audience, but we know that American Indians have the highest rates of smoking cigarettes by race, and that these rates vary quite significantly by region, with the highest prevalence being in particular in the upper Midwest Plains region. In the Great Lakes region, we know that these rates are higher as well, and that happens to coincide with states where National Jewish Health operates quitline services. And we know that commercial tobacco use is a primary driver of early death and disability in the United States, and in particular in American Indian communities. And that includes things that we all know, things like heart disease, lung cancer, but many people don't realize that even diabetes and poor musculoskeletal health, like fractures and things like that, are impacted by commercial tobacco use, in particular smoking cigarettes. But we also know that interest in quitting is similar to other groups, and so that opens a window of opportunity where we can better deliver services to Indigenous communities for people who are looking for help with quitting. I like to layer on a discussion about the traditional tobacco movement, because that's where I really see the AICTP program fits. is not that we are at National Jewish Health qualified in any way to promote the traditional tobacco movement, but helping us to really understand the history and role of tobacco and how that varies by tribe, and that the history of traditional tobacco always exists within the context of colonialism, and that the loss of land and the freedom to practice traditional ways has been a major influencing factor in terms of these high rates of commercial tobacco use, and how the introduction of commercial tobacco products within that context has really driven an epidemic of commercial tobacco product use. And that as part of the traditional tobacco movement, it's so important for us to ensure that we're distinguishing between traditional tobacco from those commercial tobacco products when we're talking about things like prevention, control, or treatment of tobacco use. And that part of, the reason I think that this program fits within that milieu is that really when we're talking about commercial tobacco cessation, it's tied in many ways to the reclamation of traditional tobacco use. A little bit about culturally tailored cessation services. So what do we know from the literature? What do we know from the evidence about culturally tailored cessation services? There's not a lot, no surprise to any of us, but we do know that culturally tailored programs tend to increase engagement, even though they may not increase quit rates. So they may not be more effective, but if people are more willing to use the program, we can potentially have a bigger population health or a public health impact by having more people engage in cessation services with at least a reasonable effectiveness similar to other mainstream programs like the Quitlink. A big component of culturally tailoring cessation services means that you engage your community to participate in the approach when you're developing and adapting programs. And that's something we'll talk about, how that is a big component of the American Indian Commercial Tobacco Program and how it was developed. We know that things like presenting accurate and specific information in culturally responsive ways is an important component of tailoring programs for cultural purposes. And then in particular within the context of Indigenous communities, understanding that traditional tobacco use can be both a protective and a risk factor for quitting. So it can both present a barrier to quitting and can also be a protective factor if people are really motivated to quit because they want to adhere more closely to the traditional uses and ceremonial uses of tobacco products. But really, we don't instruct people on how to use products in a traditional way, but recognize that it requires really careful conversation. It requires the support from the community or from elders in the community and their guidance on how to use traditional tobacco in particular when we're looking at it from a protective standpoint. The other piece that I will say, and a big thank you to the Michigan Department of Health and Human Services, is that commitment to funding culturally tailored cessation services is vital. It takes so long to get out word about these programs and the importance of these programs and the fact that they're available to folks, and that it takes a really long time to build that word of mouth so that people understand what the program is, that we can have the opportunity to present like today on this webinar to let all of you know about this program and what it is. And we have to sustain that over the long period of time. Otherwise, we decrease trust in the very populations that we're trying to reach if our services are not sustainable. A little bit about what we know then about how American Indian Quitline callers participate in quitlines. And so we know that national data, so the North American Quitline Consortium and the CDC, the Centers for Disease Control and Prevention, collect data on the number of people who are using quitlines every year. And they look at those differences by race or ethnicity. And generally what they see is American Indians or Indigenous people who use commercial tobacco products tend to have about equitable reach with other populations who are using commercial tobacco products. But what we saw in National Jewish Health's internal data is that when we looked at, okay, if they're calling and they're registering for services, are they engaging in services at an equitable rate? And what we saw this is looking at data now going back about 10 years, that we had about 20% of American Indian callers would drop out immediately after intake, which was compared to about 10 to 15% among non-American Indian callers. and that 60% would drop out after their first coaching call versus about 40% of non-American Indian callers. And we could see that 20% were completing 3 or more coaching calls, which is where the evidence really starts to suggest a dose response, meaning the intervention is most effective if people complete at least 3 coaching calls. And we were only getting about a fifth there versus about 40 to 50% among the non-American Indian population. And so on average, our American Indian callers were completing about 1.7 coaching calls on average compared to 3.2 for other participants. So that suggested that even though reach was there, that potentially the engagement in services was not the same. And so it allowed us to ask a question of, if we know that motivation to quit is not dissimilar, it is very similar to the general population, why might engagement be lower among our American Indian callers? And my predecessor, Amy Lukowski, who was the clinical director, and her colleagues did a research paper to look at what reasons for dropping out of services might look like and what some of the reasons might be. And what they found was that American Indian callers tended to report lower, who didn't complete as many calls, tended to have lower education level, an earlier age of commercial tobacco initiation, which suggests potentially a higher nicotine dependence, higher mental health comorbidity, and we know that that's a common risk factor for commercial tobacco use is mental health conditions that are along with tobacco use, and that our American Indian populations tended to have more physical health problems as well. And so these were on average folks who had probably a higher nicotine dependence and more physical and mental health conditions compared to the general population of quitline callers. And then when we add into the background of that a higher community prevalence of commercial tobacco use, it means that people are more likely to live with somebody else who smokes, and how they see quitting is also different. Just those norms about cultural norms or community norms about quitting and the importance of quitting are very different when you have a high background rate of commercial tobacco use in your community. If you see half of the elders in your community or half of the adults in your community are using commercial tobacco products, it makes it seem more normative and makes it harder in many ways to quit. And then also may be less support for quitting in that setting as well. And then we know from the literature that, again, that there's lower trust in healthcare services that are outside of the local community, and that we know that commercial tobacco cessation requires culturally tailored messages about quitting in order to reach Indigenous communities. So that's a kind of understanding the need from the data side. We then went in and did a literature review of understanding the best practices. Again, there's not very much information about cessation services for Indigenous communities, but what little there is integrated into the program. Then we engaged with subject matter experts, people who were working in the traditional tobacco movement or in commercial tobacco control with American Indian populations. They were part of an expert panel of people who were helping to tailor services. And then, as I mentioned, one of the critical components of tailoring services is to ensure that you've engaged your community in the adaptive process. And so when this program was being developed now in 2013, 2014, we had sought community input through talking circles in Montana and Michigan. And so the program is really built on those experiences and the feedback that we receive from the community. And 4 main points that we pulled from those talking circles included feeling a cultural connection to the coach. And that was really one of the most important things, is knowing that the person who you were speaking to comes from your same culture, that they are also an Indigenous person who has an understanding of ceremony and of tradition and of connection to the land was very important. And what we heard was it didn't need to be from the same tribe. It didn't need to be a coach from the same tribe, as long as the coach had a connection to their tribe. And that we had to adapt the entire process from intake all the way through coaching to make sure that it was culturally responsive. So in particular, one of the things that we looked at was we know that in many communities, indigenous communities, asking a lot of close-ended questions or even just a lot of questions with somebody and not sharing information can be quite feel very intrusive and be really not a culturally appropriate way of communicating. And so the intake was adapted to make sure that we have permission to continue when we are asking questions. And of course, another component was distinguishing traditional from commercial tobacco products as being an important component. And so that is what the program is. The American Indian Commercial Tobacco Program is staffed entirely with American Indian coaches, people who have a connection to their home community, who have a deep understanding of tradition and of ceremony and the importance of those pieces in somebody's cessation process, that the intake and the coaching process are very flexible to support participants in their needs for communication, and that we provide a longer duration of support along with those quit medications. So the standard program is usually between 4 and 5 calls. In the AICTP, we offer 10 coaching calls, and that allows our coaches to really take a lot more time to build rapport with the people that they're speaking with, that it gives them a chance to share and to learn and to understand more about who they're working with. And it's really important. In particular, one of the things that we saw in our evaluation data is that many of our AICTP participants wouldn't start even ordering quit medications sometimes until their second, third, fourth coaching call. And we want to be able to support them over a longer period of time. The program also had a dedicated website and a toll-free number so that people can reach the program directly. And as I mentioned, it's been live now just coming up on 9 years. So a very exciting, long-standing program now for us. This is a quick map just to show you where the program is offered. Michigan's sort of there on its own, but as you can see, it's a lot of it is in sort of the West, Mountain West, Midwest regions. But we also have several of our states in the Northeast and Mid-Atlantic also support this program for participants in their state. As I mentioned, there's a dedicated website, so AIQuitline.com or .org. Either one will take you through. That's to make it as easy as possible. Once somebody goes to that site, it does redirect to another longer URL that makes sure that when somebody enrolls, we know what state they're enrolling from, so they don't have to give us a lot of information that way. But there is a dedicated website, a dedicated toll-free number, which is 855-5-AI-QUIT. We tried to make that one. That's a newer number from the last 4 years to really make it as easy as possible for folks to be able to get to the program. They can still call 1-800-QUIT now if they're aware of that number, or if that's something that you're already promoting. No harm there. Once somebody calls in, if they're from Michigan, we will offer them, one of the first programs that we offer them is the American Indian Commercial Tobacco Program if they're interested in enrolling there. We do also have a small promotional toolkit with images that were selected by community members with reasons that we heard from participants about why they were quitting. These are available if you're looking for some promotional items for your community, for your health center or something like that. We can make these available to you as well. They have just very brief information and are designed just to let people know about the program and that help is there for them with quitting. Getting a little bit click happy there again. And so one of the things we wanted to talk about today is about referrals to the American Indian Commercial Tobacco Program. So if you're working in a healthcare center or working with providers to try and get them to deliver more intervention around commercial tobacco use, you can actually direct them to the same website, AIQuitline.com or .org, which will redirect again to the Michigan specific site. Once they get there, they can select here. I put you can see on the screen here the provider referral, and underneath there, it's hard to see right in this slide deck, but there's a link to a provider web referral, which opens up here. They can enter the person's name in there. It shows all of the required fields. Once they complete it, they can submit it, and we will receive that referral and make a call to the participant. The fax form is not available on the AI Quitline website, but it is available from the Michigan Quitlogix website, which is michiganquitlogix.org, michigan.quitlogix.org, I should say, and they can use that fax form as well. So you can refer either to Michigan Quitlink or directly to the AICTP. In either event, we will always offer the American Indian Commercial Tobacco Program to anybody who identifies as being American Indian or Alaska Native when we call them. So what happens when you make a referral? If you're in a HIPAA-covered entity, which is things like healthcare centers, behavioral health centers, anybody who's has to protect data the same way that a hospital would or a healthcare clinic would, who are covered by HIPAA, these providers can opt in to receive feedback on the referral at up to 5 time points that are aligned with the referral and with the enrollment status of the participant. So for example, when the referral is received, we'll send you a note back to let you know that we received it and that we're processing it. We'll let you know when that referral is closed with the outcome of that referral. So did they complete an intake? Did they decline the referral when we talked to them? Or were we never able to reach them? Were they an unreachable referral? We will let you know and encourage you to follow up with them again at their next visit. When they enroll in the program, we will also provide enrollment status changes. So when they enroll, when they disenroll, either because they were unreachable, again, maybe they didn't complete all of their coaching calls and we weren't able to reach them, they're lost to follow-up, you may think of it that way. Or if they complete the program, we'll send you a progress note to let you know that they're the latest status on their enrollment. And then also when NRT products are delivered. And sometimes these things happen in the same thing, so one progress note may tell you that the person enrolled and that they ordered NRT, and then we're giving you all of that information at one time. Providers can either opt in to get those fax back reports or those feedback reports by fax, so you give that option, or you can receive it by secure email, where we will send you a secure email and you have to download it, you have to create a password, download the information, and then you can get it through a PDF process to view the fax back report or the feedback report. So that's a little bit of information about the referral and the feedback reports that go to providers. So a little bit about what happens when we do connect with somebody. What does that process look like? So when we first talk to somebody, whether they call in or whether they're referred by their provider and we are speaking to them on the phone for the first time, the first thing we do is a quick registration, eligibility, and intake process. During that eligibility process is where we ask people if they identify as American Indian or Alaska Native. And if so, we let them know that we have a culturally tailored program that focuses on the differences between traditional tobacco and commercial tobacco products, and provides additional support. And they're then able to opt in or opt out of that program. We get about 15 to 20% of people who identify as American Indian opt in at that point, because because it's a culturally tailored program. A lot of people who maybe identify as American Indian don't feel a strong connection to their traditional, to their home community or to their traditions, so they may not want the program, but it's available to them. Once they've completed that intake process, we get them into the enrollment process, where we're asking them about their readiness, send them their participant education materials. We send them the My Quit Journey workbook, which gives them some tools to use for a self-guided quit attempt. But we also encourage people to come back and to do more coaching. And as I mentioned, in this program, in the American Indian Commercial Tobacco Program, all of that coaching is completed with one of our American Indian coaches. So all of that support is coming from people who are part of the community. Along with that coaching process, our coaches will recommend and talk about how to use nicotine replacement therapy. That's things like patch, gum, or lozenge. They talk about how to use it, and they'll order it for them to get it shipped directly to their home. Within the AICTP in Michigan, participants are eligible for up to 8 weeks of nicotine replacement therapy as either monotherapy, so just a patch, gum, or lozenge on its own, or as a combo therapy. So they can get patch with gum or lozenge, which we know then is more effective at actually helping people quit, so getting them to use those combo therapy medications. And then at 7 months after they complete their intake, if they've consented to follow up, we have a third-party research firm that we engage who calls people to see, did they quit? Unfortunately, the response rates are very low for quit lines. So the data is, and when we're looking at our American Indian Commercial Tobacco Program, every year we don't get very many survey responses. So we tend to group them across the entire program so that we can look at what the success is from year to year. A little bit more about telephone coaching. So as I mentioned, the primary component of our coaching model is really motivational interviewing. We then add on to that things like stages of change and some cognitive behavioral strategies. So when we're doing coaching, that motivational interviewing approach there's another guide, I think it was published by the Ashline folks back in the day at the University of Arizona, who did a culturally tailored version of motivational interviewing, which we provide to our American Indian Commercial Tobacco Program coaches. But really just to emphasize that the coaching is not scripted. It is very much a conversation. It is listening, summarizing what somebody's saying, providing a lot of reflections about the person's motivation. It's very collaborative. It's very, very person-centered in terms of helping somebody to quit. So just to let you know that we are not there to yell at people. We're not there to tell them to quit. It's really about uncovering their motivation. It's very conversational. It is not a scripted. It's not a robot. This is really, they get to work with just wonderful folks who want to work as coaches on the quit line. The readiness to quit is really thinking about stages of change, and we're really moving people through that process. It just allows us to tailor the conversation. We want to guide people alongside them on their quit journey until they're completely commercial tobacco free. And that cognitive behavioral approach is really thinking about the connection between our thoughts, our feelings, and how those lead to behaviors. And a lot of that comes into play when we're talking about how you develop coping skills for things like triggers to smoke or for nicotine cravings to help somebody with that process of moving forward. So if you were on the webinar that we did a couple of years ago now, I've presented some of these data before, but I'm going to highlight them again. As I mentioned, when we looked at our overall the first 5 years of the program, and we'll be coming up on another 5-year round here in a short little while, so getting ready to do another round of evaluation on the program, we found that 14% of callers who identified as American Indian opted to enroll into the program. And the folks who were enrolling in the program tended to be a little bit older. They tended to have slightly lower education level. And interestingly, more men were willing to opt into the program, which suggested that we were reaching a population that quit lines don't reach very well, which are some of the opposites of these groups, which is, quit lines tend to be used more by women than by men. And so the fact that this program was being selected by more men was really important. We'd also found that folks who were opting into the program tended to be more likely to report having a mental health condition, especially depression, anxiety, and having actually both depression and anxiety. We also saw higher rates of substance use, and people saying that they had post-traumatic stress disorder would opt into this program. And we saw this both in our data and in interviews with our coaches. What they were identifying is that a lot of people with mental health concerns who identified as American Indian were more likely to opt into the program, and it seemed like a component of that was really their overall recovery was tied to trying to better develop their connection to their American Indian past or their indigenous roots to try and recover from their behavioral health condition as well. Folks were more likely to live on tribal land, and nearly everybody smoked cigarettes, but there was also more use of cigars and chew or dip compared to American Indian callers who were in the standard program. And of those participants who did enroll and complete a coaching call, more than half went on to complete more than 3 or more coaching calls, and this was compared to just a quarter in of American Indians in the standard coaching program who would complete 3 or more coaching calls. So that's a full doubling. That was a really important finding, is to see that this program is engaging people for a longer period of time. And we saw that 14% were able to go through all 10 calls compared to only 10% of American Indians who completed just the 5-call standard program. So more folks in the AICTP were completing 10 coaching calls than American Indian callers in the standard program receiving only 5 coaching calls. And the average was up to 3.9 coaching calls on average compared to just 2.1 in the standard program. So definitely more engaged in the program. We did see, however, that fewer participants were using nicotine replacement therapy, 71 versus 79%. Some of this was probably requiring, they had more medical conditions, as we already identified, and that they were more likely then maybe to require medical authorization, and maybe then have lower likelihood of getting that authorization to access the medication benefit. And that means that it takes more coaching calls to get NRT. And we did see that those participants were often not ordering NRT until sometimes their 2nd, 3rd, 4th coaching call. But once they did receive it, they were receiving more on average. They would use about a little more than 6 weeks on average compared to less than 6 weeks among American Indians in the standard program. So that's another important finding. When we look at quit outcomes, we saw that 35% of the participants with at least 2 coaching calls made a quit attempt. So that was our ability to look at, did they ever make a quit attempt? And those participants who did make a quit attempt tended to be healthier. They were more likely to not report a mental health condition and had used nicotine replacement therapy. And an important component of this program is that even though we want to help people with quitting smoking, we're really interested in also helping people to reduce how much they smoke if that's their goal. We really want to work with people who are trying to change their behavior and understanding that if they can't get to a full quit attempt, can we actually help them to reduce how much they're smoking? And what we found is that 2/3 of the participants who didn't make a quit attempt did report that they reduced the number of cigarettes that they smoked per day. And those who reduced were more likely to have completed more coaching calls, and that meant that then they were getting that support to reduce how much they smoked. And the quit outcomes were very positive. The national benchmark for quit lines is about 30%, and the 7-month follow-up quit rate in this program was 38%. It has remained consistently quite high for the program, which is really a testament to the importance of having this program be part of what people can access. We also look at satisfaction information. This is things like, do they, in particular for this program, do they feel like the program is welcoming? And we found very high perception that all of the program components like coaching, text and email were welcoming, very high satisfaction rates with the coaching, the text and email programs, and in particular the free quit medications they could receive. We asked people if they would recommend the program to another person like them who was trying to quit. We found 94% said that they would. And really importantly, one of the things that we found when we asked people what other resources they were using to quit, 42% were saying they were only using this program to help them with quitting. So, really speaks to the uniqueness of this resource, but also the importance of having an accessible resource to people in the community to be able to use as part of their quit attempt. The last thing I want to share with you here from the evaluation was some quotes that we heard from participants. So the first one here is, when I saw the commercial on TV, I had my doubts, but as I talked to my coaches, I realized I could do this. I was in poor health. I'm a diabetic with heart disease. All I did was make up my mind that I was going to quit, and my coaches stood on the side and gave me the push I needed. Thank you. My life has changed a lot. Another participant said, we touched on the importance of tobacco in traditional ceremonial practices and how that affects my quit. It was very helpful. And finally, I felt that Natives can understand the struggle against cigarettes for Natives. Thank you. I now have 9 months without a cigarette, and I owe my success to the Native American Quitline. So some really nice quotes here from participants. So what can we say in summary? Well, we know that culturally tailoring quitline services for commercial tobacco treatment with American Indians certainly increases engagement. We can see that the overall number of coaching calls that people complete is higher. We know that a culturally tailored quitline program for American Indians is effective in helping people quit, and so much so that it exceeds the national benchmarks for services. And again, just as I've said before, and I'd like to reinforce, is that this really requires long-term commitment from all of our stakeholders to sustain it, from funding the programs, to promoting the services, to building trust with the community, to demonstrate that these programs can be part of the traditional tobacco movement by reducing the use of commercial tobacco use in communities. And with that, I want to close with opening up the floor for some questions.
Hi, Thomas. We've got a couple in the chat in the Q&A that I'll read off. So the first question is, does the coaches from the AICTP program provide information about lung cancer screening to callers?
I'm going to have to check on that. I'll have to check because I think we do that in Michigan. We offer information about lung cancer screening. I'm going to have to check and see if we've integrated it into the American Indian commercial tobacco program intake. The reason I don't know that off the top of my head is because it is a completely separate intake process for that program, which is different, lots of similarities, but some differences from the general Quitlink program intake. So I'm going to have to check. It's possible that we don't currently have it in there, but I'm going to have to double check and we can get it in there though.
Okay, the next question is, we have a few kids who are interested in quitting vaping nicotine. However, it's illegal for youth under 21 to use nicotine. They find a way to get it anyway and become addicted. What resources are available for that population?
Yeah, a couple of pieces in there. One is it's not illegal for them to use nicotine. Nicotine replacement therapy is a medication that is available for helping people, and the FDA requirements for the approval for that medication is for anybody who's an adult, 18 or older. Now, that is, there are people who misinterpret that, and there are people who will, even in pharmacies, refuse to sell nicotine replacement products to people who are under the age of 21. We don't have that restriction, thankfully, so we will provide those quit medications to people who are looking for help. We do require them to be at least 18 to be medically eligible for those services. Now, for accessing commercial tobacco products, thankfully, they do have to be at least 21. Ideally, they'd be 24 or 26 or maybe 85. We could set it there to really, stop anybody from being able to buy these products. But as long as they're available, we know that a certain amount of them will be diverted, and young people who really should not be using any nicotine products get access to them and use them. So, there are a couple of resources that we have. Certainly, people who are under 18 can still use the American Indian Commercial Tobacco Program. They can enroll in that program directly. Our coaches are trained to work with young people. And as I mentioned briefly, we do also have the My Life, My Quit program, which is tailored specifically for youth. The coaches in that program don't have the training to work with traditional tobacco. They have some knowledge of it, but certainly wouldn't be providing that culturally tailored intervention. But we will offer both interventions to people. They can, if they're under 18, they can access either our American Indian Commercial Tobacco Program, work with one of those coaches, or they can enroll directly in our My Life, My Quit program, where they can receive things like coaching over live texting. So they can text Start My Quit to 36072. They can call a different toll-free number. They can go online and sign up at mylifemyquit.org, but all of those, or .com, either one will work. They'll both redirect, and they can enroll there as well. So again, just to reiterate, they can choose either the dedicated American Indian Commercial Tobacco Program, or they can use the My Life, My Quit youth tailored program.
Thanks, Thomas. There's no more questions in the Q&A box, but if anybody has any more questions, you can add them in the chat or the Q&A, and I will read them out. And thanks, Karen, for adding that link into the chat box.
Well, thank you everybody for attending today. And we do want to remind folks that we will have an archive of this webinar. It will be available by the end of the week. This is actually a pretty busy week for us, so we won't be able to do the normal 24-hour churn that we typically do. But we will make sure to have it up before the end of the week this week. We're also going to be sending out an evaluation just to let us know how we did on today's presentation as well. Also on the archive, there is a link to the archive page in the chat box. We'll also email the archive out once it's ready to go here. So feel free to also keep in touch with us through keepitsacred.org. There's also plenty of other archive technical assistance webinars and other cancer and commercial tobacco prevention resources for tribes and tribal organizations. And if you have any other questions, feel free to reach out to us. Is there anything else to add from Dave or Thomas or Karen? Well, with that, we will go ahead and close out today's webinar. We want to thank everybody again for attending, and we hope you have yourselves a great rest of your day. Thank you very much.
Have a great day, everyone.